what we'll do is we'll start with the very first presentation on the James Lovell Medical Center. We are pleased to have Lieutenant Commander Lovell Ricino, and he is the Assistant Director of Patient Services at Captain James A. Lovell Federal Health Care Center. And they provide the highest quality of patient services to all TRICARE and veterans beneficiaries. And their motto is readying our warriors and caring for our heroes. That's you in this room, the heroes. Previously, he was the Department Head of Physical Therapy Services at the Department of Veterans Affairs to manage a diverse and talented group of VA and DOD physical therapy personnel in pursuit of a common goal: take excellent care of our beneficiaries while taking excellent care of each other. He comes to us as a doctor of science, orthopedic, manual physical therapy, along with a lot of other educational benefits. And he speaks multiple languages: English, Italian, French, and Spanish. And his presentation today, for my benefit, will be in Spanish. And maybe we can talk about good in English. I'll try. By the way, I come from San Antonio. That's the reason why I said Spanish. But he will make his presentation on the physical therapy activity. By the way, I hate to see you after you do that out in the back of my shoulder blade here. Commander, if you would, please.
Muchísimas gracias. Entonces, thank you, Colonel. And it is a pleasure and an honor to be here before you. Thank you for this opportunity. So I'm from the Captain James A. Lovell Federal Health Care Center. We are the first integrated Department of Defense and VA entity that provides medical care from recruits to after you're done with your military service. As you know, we're named after Captain James A. Lovell. Has everybody seen Apollo 13? Okay. So this famous astronaut brought his crew home safely, faced severe challenges, solved them, and got them back. And so he inspires us daily to face our own severe challenges, bringing those two systems together, solve those situations, and provide world-class health care for all our patients. Now, I understand that most of you are probably from the south suburbs, so you'll be going to Hines and Jesse Brown for your VA medical care. However, so this is a higher level view of what we're actually doing at FHCC. This is for everybody's benefit. So this is the same presentation that we provide for the government officials, the high level leaders that come to visit us all the time. However, I'm going to answer as many of your questions as possible, and if you have questions that I can't answer, I'll write them down and I'll get you in touch with the right people at the FHCC, which is what we shorten this long name to. So, if you are able to come up and see us at the FHCC, let me just describe to you what we actually have to offer. So, primary and emergency care. We have a world-class emergency room. We have family practice and primary care, internal medicine, and first for the VA, pediatrics. Okay, so specialty medicine, neurology, audiology, cardiology, gastroenterology, respiratory therapy, a whole bunch. Surgical services, we have general surgery, podiatry, orthopedics, ophthalmology. For health promotions, for those of you who are just trying to stay healthy, we have nutrition, we have diabetes clinic, we have preventive maintenance, we have physical therapy that's geared towards prevention, smoking cessation, we have a whole pharmacy. We even have a mail order from both the VA and from TRICARE available to you. We have acute and long-term mental health care. If you don't remember, North Chicago used to be the area's mental health expertise. And we also have geriatrics and extended care. So we are the first Navy long-term skilled nursing facilities. So a lot is going on at the FHCC. The thing to remember is that we are the first. So there are a lot of things that we are trying to solve so that we can bring this to the rest of the country. There's other places in Biloxi, Mississippi, and Las Vegas, Nevada, where the VA and the DoD are working side by side. Two different systems sharing the same space. This is not the case at the FHCC. We are totally integrated. If you come to see primary care, you may see an active duty Navy doctor. When you come to physical therapy, if you're coming with your VA benefits, you may see an active duty Navy physical therapist, etc., throughout the continuum. So again, we see everyone from recruits to after you're done with your military service. So, about Lovell FHCC, as you can see, that's a map. The blue over there is the Lake Michigan. We're in North Chicago, okay? So right next to Great Lakes. We share space with Great Lakes. Our combined mission, readying warriors and caring for heroes. And the readying warriors, again, is the recruits, and caring for heroes is all of you. And we are a gigantic facility, 107 acres just on the West Campus alone. But we're also on the Naval Station. So we have clinics at the Recruit Training Center and also at the Student Training Center right there along the lake. And as far as our outreach to the community, we have 3 community-based outpatient clinics. One in Kenosha, so southern Wisconsin. If you have any friends in that area, please let them know that we're here for them. We go as far west as McHenry and as far south as Evanston. So can everyone hear me okay? Just making sure. Next slide. So this is a bird's eye view. Okay, so this is where we're at. Where it says East Campus, that's towards the lake. That is building 237, the Fisher Branch Medical Clinic. If you go just below East Campus, that's the Recruit Training Command. And right below that, where it says West Campus, that is the main clinical areas for the FHCC. And that is the old North Chicago VA campus. So we've got new parking, we've got a valet service, so if you're coming up to us, just drive on up to the door, hand your keys off, and we'll park your car for you while you go take care of your medical needs. Next slide. So, reporting structure. We are the first. Again, we have a lot of people that want to make sure that we succeed. So starting at the bottom, as you can see there, there's patient services, patient care, facility support, dental service, resources, complete medicine. Those are our 6 directorates. That's how we split it up. I'm from patient services, and we're the cats and dogs. We're everything that doesn't fit into doctors, nurses, taking care of the facility, taking care of the money, taking care of your teeth, and taking care of the sales. So it's a tough job that somebody's got to do. The stakeholders are the veterans, the veteran groups, the tenant commands, all the commanding officers for those tenant commands, as well as their ombudsman. They tell us what they want, what they need, where we're not fulfilling our mission. And they have direct access to our director, who is a VA, Special Executive Service, our deputy director, who is active duty Navy 06 captain. We also have a command master chief to make sure that we're taking care of the recruits properly. So that mission is still paramount. We have input from the advisory board, which comes from VISN 12. Dr. Borowski is the head of that, and Enemy UMed, which is Admiral Wagner. So that reaches back all the way to Portsmouth and all the way to Washington, D.C. As if that wasn't enough, to make sure that we're still doing everything right, the Health Executive Council, which is the undersecretaries of health care for both the VA and DoD, and their staff, they're also making sure that we're doing right. And then above them, the Joint Executive Council, the actual Secretaries of Defense and the Secretary of the VA are both also involved. And we see them, we see Secretary Shinseki on a routine basis. So talk about being under the gun and the magnifying glass. That's us. So we have a lot of pressure bearing down on us to make sure that we do the right thing for all of you. So if you have anyone that can come to us, please do. Sir, did you have a question? Yeah, please feel free to ask questions, and I will make sure I'm still on time. Next slide, please. Sir.
So, in response to the latest focus on the VA, how is it impacting the claims that are coming in, claims that are in the past, because you've got, I've actually got some that's been pending since 2009 for a VA hearing, blah, 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 you know.
Well, yes, sir, it has impacted us. In fact, this summer, yes, sir, thank you. So how is the current focus on the VA and the VA not being able to process claims in a timely manner, how is that affecting the FHCC? Just this summer, we have focused on an influx of those claims. We have been given our fair share by the Veterans Benefits Association, so we are working through that just like any other Veterans Administration center. Okay, so our fair share is about 1,200 claims just this summer alone, and with regard to audiology, we've had 120 claims just for that.
Yes, I have a question. I am, in regards to eligibility to use the FHCC, I am retired, 28 years in the Air National Guard of O'Hare. I just started drawing my retirement pay a year ago. My active duty is majority, 180 to 190 something days is for training. Most of my active duty was training. Now, my primary health care is Medicare. My secondary is TRICARE for life. My question is, would I be eligible to use FHCC?
Absolutely. We have both retirees and we have VA. So we have TRICARE and VA benefits. And we can even guide you towards which one is best to use throughout your stay there.
Even though my military time is National Guard time.
Right.
Okay, I would be able to use that. Now,
the significant thing is to make sure they understand which system you're coming in.
Right, exactly.
Because if it goes to VA, you may get a copay. If it goes to DOD retiree, TRICARE, then there's no copay.
Right, exactly. And did everyone hear that? No. Make sure you tell them when you are showing up. And in fact, my patient admin person made sure I told you this. You need to tell them which benefit you want to use. And we will help you use the benefit that is the lesser impact on you. Yes, sir.
I have a friend of mine who's a 30-year reservist. The only active duty time he had was during basic and the 2 weeks AT every year. Would he qualify?
He should qualify, yes, sir. Yeah, I'll get you the information you need and the phone numbers to give to him so we can...
Now he lives in the Rockford area.
Was that?
He lives in the Rockford area.
Oh, okay.
They're not considered
right.
Federal active duty, not considered a limit.
Right. So we can... Okay. So we can ask those questions. Yes, sir.
A quick comment. I just read a couple days ago that that if you're under Medicare and TRICARE for life, that the VA isn't going to reimburse, that they don't bill Medicare, and that's going to be a change to the way they've been operating, be effective the 1st of October. So anybody who's been using it, and I'm not there yet, but I was planning on using it there at Hines. But if it's not a service-connected injury illness,
right.
They're not going to reimburse you through Medicare. And TRICARE will only pay 20% at that point.
Yes,
TRICARE for life. So if you're in that situation, find another doctor, the preventive care. Or,
right. And I don't want to step on my TRICARE colleagues' feet. So she's going to be presenting at 9:30, so we can address that as well. Yes, sir.
So, do you have because the biggest question for many retirees will be if they have disabled children, before, whatever, and then you use them as a survivor benefit, how does it affect care for disabled children? Because it sounds like in pediatrics, you kind of thought about that, but the law hasn't changed yet to, like have special needs trusts and all that stuff. But yeah, they also have to watch it because if you get another benefit, they could lose something on the other end, like Medicare or Medicaid.
Right.
Have you seen any response in that field or area?
No, actually, we're still trying to figure that out. So if you want to talk later, and I can write down your question specifically and find out what we're doing at the FHCC. Just moving on real quickly. The Lovell FHCC team is here. This is our director at the top. That's Mr. Patrick Sullivan. Our commanding officer is there, the deputy director. That's Captain Jose Acosta. Master Chief Coffey is our Command Master Chief, and our XO is Captain Oxford. And these are our primary associate directors below. And under the Associate Director for Patient Services, Dr. Sarah Faust, that's me. Next slide, please. And so again, just to show that we are combining both the VA and the Navy, that's how many civilian VA employees we have, 2,046. And we have a contract of 36, and that's our total. And everything combined with the Navy's civilians, active duty, and contract is 3,000 members and personnel of our staff. Next slide. So this is an eye chart. You don't have to read through that, but these are the benchmarks that we are being measured on every day. We carry these things and we take them very seriously. So we look at patient satisfaction, we look at medical readiness, we look at how we use our money. Right now we're locked into how much money we're actually allowed to use until 2015. Okay, and that's Congress that said, here's your pie, use it, we'll review it in 5 years. We're looking at our clinical and administrative performance measures. Access to care is a big one. We look at evidence-based healthcare measures, so we're looking at the real science behind providing our healthcare. We look at officer and enlisted retention. So we're seeing things from both sides. And we're even looking at how well we train our folks, whether they're civilian or military. Okay, so those benchmarks, as you can see here, looking from 2012 to 2013, we are well within our benchmarks, and we take pride in that, but we know it's not over. We are anywhere from 78 to 87%, and that's where they want us to be. Yes, sir.
When did somebody come to your facility? And to the history, the people that have been walking in the last few months, the medical reasons that they would come, obviously, if I'm having a heart attack, I'm probably not going to drive out there right away.
Sure.
But, you know, are you getting people that will transfer from a hospital over to you, or is it basically, or do you have a primary care facility where?
We have a primary care facility. The reason that people primarily come to us is they are getting out of the military and they want to have their health care nearby. So,
do they come in for physicals, or?
Yes, they can.
So you don't have to, so you wouldn't necessarily wait till you have something wrong with yourself, you would just go in there, get a physical, and go through?
Right.
Okay.
So the question was, how do people come to us? Why do people come to us? A variety of reasons, but primarily it's because people are leaving the military and they want to have the health care that we can provide. And we're in the area. Aside from the active duty, which we are their medical treatment facility and they have no choice about it unless we send them out, people choose to come to us because we offer good health care and world-class health care, and we are close to them. They can come in for primary care.
Pharmacy.
And the pharmacy. Which is one of the divisions I own. So if you have questions, I can answer those specifically. Okay, so far we're doing a pretty good job. We have been driving ourselves to achieve. Just to go back into the history, we started as a concept in 1996 after Bragg. Senator Kirk was a big driving force. The North Chicago VA was going to be closed down because they were going to move everything back to Hines, back to Jesse Brown, and back to Milwaukee. At the same time, the hospital, which serviced all of the active duty side, 200H, building 200H, which is no longer there, they were scheduled to be rehabilitated, renovated, and when they started looking at that, they found it was going to be very costly because of the structural integrity, and they were going to need to build a brand new facility. So Senator Kirk got it into his mind, hey, why don't we combine? Why don't we look at moving towards the future and combining both the VA and the DoD services in this area? And he got a lot of support in Washington, D.C., and they said, why not? So, of course, they looked at all the issues, 2 computer systems, 2 cultures, right? 2 different missions. And they said, how can we make this happen? So from 1996, they went into deep planning. They went to the boots on the ground and said, how can we make this happen? And we started in 2003, or we completed the first move in 2003. We combined the behavioral health units, so mental health, for Naval Hospital Great Lakes and North Chicago. And from fiscal year 2003 to 2007, we saved $5.4 million. And we also moved our blood processing center. Now this isn't a small blood processing center. This is one of 2 facilities that provides blood to the entire DoD, the Marines, the Air Force, the Army, and the Navy, downrange. And they put that in the North Chicago VA at the time, and we saved on trying to build a new facility. So we saved $3.1 million there. In phase 2, which was completed in 2006, we combined the inpatient medicine, emergency room, ICU, surgery departments. That saved us 51 jobs, 51 full-time employee equivalents, and we saved $5.8 million from 2005 to 2007. Since then, our mission has expanded, so we probably took back all those 1,500 jobs already. And in phase 3, we started in 2010. That was the rest of the integration. We had to build a new wing for the Navy side. Cost us $67 million, but we're operating at a cost of saving a cost of $19 million by doing that, by putting everything in one place. So we're saving money. We're trying to consolidate taxpayer money into one place and provide one system from recruit to after military service. And we're being reviewed all the time. Dog and pony show all the time. Yes, sir.
So you say that you combine the systems, and it seems to me that seems to be the key to the VA problem, because they can't get records from the military, they don't have access to it. It seems to be the central problem across the country, and why these claims are taking so long to file. And I understand, I don't know if this has happened yet, that they've made a strategy change where they're now accepting civilian doctors' analysis, or their whatever they come up with, and now they're accepting civilian doctors. Is that speeding everything up, or is that hindering, or?
Good question, sir. So we're accepting civilian doctors. We're trying to. The question is, because we're accepting civilian doctors into the military, into the VA, is that speeding up the system? And it seems like the combination of the VA and the DoD is going to speed things up as we put things under one roof. And this slide directly demonstrates that. So here, if you look at the green line on the far left bottom, that's how long it takes for the FHCC to process the integrated disability evaluation. So when people are leaving the military, the VA and the DoD are supposed to be in partnership to evaluate that person's disabilities. The DoD average is about 130 days. Okay, the USMC average is about 125 days. The Navy average about 90 days, so pretty good. But we're under 60 days because we have everybody under one roof. So does that help? Absolutely. Are we taking everybody who can help us with that? Absolutely. We're taking on temporary staff to get down through that backlog as well. So, yes, sir.
So it seems to me that anybody that has a disability or has perhaps something that may have been caused by service is better going there, because you're going to get better service than going to Jesse Brown or Hines or wherever
Right.
else.
I have a friend of mine who just retired from the Navy, and he was in Michigan, at the University of Michigan, actually, as the NJROTC commander, and he drove all the way to FHCC to get everything done instead of having to go through local VA, because he knew everything was under one roof and it would be very timely. Plus, he had a free place to stay at my house, so. So we talked about all the things that we do, the Readying Warriors and Caring for Heroes. This is what we do every day. 3,000 outpatient visits, almost 800 dental visits. We have a daily census in the hospital of nearly 300. As you can see in the nursing home, we have 130. our ED visits, we do about 6 surgeries a day. Our lab is very busy. Radiology is very busy. And the pharmacy, it's crazy busy. But we also have the other mission. We still have people who go downrange. We still deploy sailors. Okay, we had 21 deployed in Continuing Promise in 2001. So showing our goodwill to South America on the Comfort. We had 38,000 recruits last year. The Navy is expanding for some reason. We are now going through 45,000 this year. And we delivered more than 178,000 immunizations throughout all our active duty staff. So we're also integrating. To show proof that we're actually integrating, before the merger, the Naval Hospital Great Lakes was downgraded to a clinic. And so because of that, we didn't have any personnel like corpsmen or the Army and Air Force medics to work on the wards because we had phased them out. We had given away those billets. We are in the process of reintegrating the corpsmen back on the wards. So if you stay on the ward, the likelihood of you seeing active duty personnel, an active duty Navy nurse, an active duty corpsman, an active duty doctor, they're very high now. And all the training that comes along with that.
On your slide, did you say you see is it 3,200 outpatients per day?
Yes, sir.
For all your facilities or just?
Right. All the facilities.
All the 3?
Right. Well, if you've got the community-based outpatient clinics, 3 of those. You've got 3 Navy clinics, and then you've got the main campus. So all of that combined, that's how many we see.
Are you actually staffed to accommodate that many people painlessly?
Are we staffed? Yes. We are staffed to do it. Is it painless? No. Honestly, I'll be honest with you, it's not painless. And that's because we're still going through this integration. Trying to figure out how to best document, for instance, how to best use the pharmacy system, for instance, as well.
So we're not going down the road of 15 years ago where you go there and wait in line all day.
No.
So one
No.
visit would take, all day. And can you set appointments?
Right, you can set appointments. Now, the other thing is, from the pharmacy, one of our benchmarks is how well do we serve our patient from taking their ticket to getting their medications in under 30 minutes. And we've been able to achieve 80%.
So it would probably be a good idea to come for a visit before you need the services.
Absolutely. Get in the system before you need it. Just,
So, like most of the VAs, they have other major hospitals because they do training that are associated. What's associated with that facility? Because I would think you'd get a lot of the interns
Right.
from those facilities that are learning as well.
absolutely. So we have Midwestern, we have Northwestern, we have, the question was what other facilities feed into our training so that we can provide the best medical health care. Right next door to us is Rosalind Franklin University of Medicine and Science. And so we have a lot of theirs. We have Midwestern, Northwestern, NIU, Loyola, you name it. They want to come and see us because they have the best of both worlds. With regards to, I can tell you from physical therapy alone, we have people coming from California to try to be an intern or resident with us. We have people from Texas because they have access to military medicine and practice. Thanks. Okay. And if you are a retired corpsman or a medic, if you want to come get a job and continue those skills, you didn't get an advanced degree, we now have a way for you to do that. We are the first ones in the VA to have that independent duty technician. So again, we talked about the nurses. We've got our cooks cooking in our kitchens, and we have our cops working as cops in the VA system. Now here's what I wanted to tell you about. It's near and dear to my heart. This is the greenhouse home. Has anyone heard of that? It is a nationwide movement towards making skilled nursing facilities more home-like. And so what we do is we have a private room. You have a house outside of the facility. It is a little bit away from the main facility. Okay, you have to be 70% service connected in order to be able to get in here. but if you are eligible, this is a wonderful place. You have nursing staff, but people who take care of you are more like family members. Okay, so you've got somebody cooking for you. It's a home-cooked meal. It's not an institutional meal. You've got a place that you can call your library. You've got a place that you can watch TV, and you've got your own room. Okay, so please tell your friends if anybody wants to take advantage of that. If they're service-connected, 70%, please.
How big is it?
It is pretty darn big. It's 15,000 square feet per home.
How many per patient, I mean, how many can it hold?
10 patients each. We have 2 right now. We've broken ground and we're building 2 more, and then we have plans to make 2 more after that.
Is that going to be at all the VA facilities or just?
So far, we're the 3rd. One is in Tuscaloosa, Alabama. The other one is in Danville, and then we're the 3rd one. Okay. And then we're also going to have a Fisher House in the future, so if loved ones need a place to stay, they can come stay with us.
What does 70% connected mean?
That you were rated when you came out that your injuries were connected to 70% of your care should be connected to injuries that were attained while on duty. And then we also have the Center of Educational Excellence. Now this place, we are going to be used not just by the VA, not just the DOD, but by all the civilian hospitals to help train. We can simulate surgery now. Before we have to actually have somebody who's not experienced cutting on you or your loved one, they can train at our facility. This should be opening later this fall, early winter. We've had a few construction delays. Now the biggest hurdle that we're seeing is that we still have 2 computer systems. We still have the VA and we still have the DOD. And we are working hard towards making those 2 integrate so that your records from military service can get to the VA and vice versa as if they were on the same system. Okay, so that's our biggest hurdle that we're facing right now. It hurts particularly our pharmacy because there's so much complexity there. We don't want to give you a medication on one system and then the same medication or a medication that could hurt you because of those 2 not being able to work together. So we're being very careful, very deliberate, but we've already met some solutions. Okay. And so in summary, we're the first of our kind. We're under the gun. We're being looked at. So now's the time to come to the FHCC if you can and avail yourself of our opportunities. Because we want to provide the best health care. We are not just the VA. We are not just the DOD. With the 2 cultures together, I truly believe that we're going to make things better in the future and cost less to taxpayers. Any questions?
What is physical therapy geared for prevention?
Oh, so basically prevention. We have a youth program.
So do you like come in and say, I'm here to...
Yeah, I'm here to lose some weight. I'm here to, just get back into shape, be fit, to be able to do the things that I want to again. We set the goals for you. We allow you to, we give you the tools that you need in your daily life to get back towards where you want to be.
Can you do it as a satellite place like
Absolutely, and the way that we do that is we're leveraging technology. We're using a lot of telehealth. So you'll be talking and looking and interacting with a physical therapist at FHCC, and you'll be in an exercise room at the CBOC. Good question. Thank you, sir. Any other questions? That's my time. I'll be here, so please come by and ask specific questions. I'll write them all down for you. Thank you.